Welcome everyone to our last presentation of the day, and this is our endocrinology panel. And we have assembled some of the best to answer all of your burning questions. So let me do some brief introductions of our panelists. If you have not met Dr. Craig Alter yet today, he is a pediatric endocrinologist and director of the Neuro-endocrine Center in the Division of Endocrinology and Diabetes at the Children's Hospital of Philadelphia. He is also president of the Pediatric Endocrine Society. We're honored to have with us Dr. Blevins, an endocrinologist specializing in evaluating and managing pituitary and hypothalamus disorders, including acromegaly, prolactinoma, and other pituitary tumors, diabetes insipidus, hypopituitarism, and growth hormone deficiencies. As medical director of California Center for Pituitary Disorders at UCSF Medical Center, he guides a team providing comprehensive state-of-the-art care. Dr. Blevins is also a member of the Raymond A. Wood Foundation Scientific Advisory Board. Dr. Vincent Horne joined the faculty in pediatric diabetes and endocrinology at Baylor College of Medicine and Texas Children's Hospital in July 2017. He is particularly interested in the care of children with late endocrine effects of cancer therapy and neuroendocrine disease, with a particular interest in hypothalamic obesity. His aim is to provide expert and quality care to all children with endocrine disorders throughout childhood, using a team-driven and collaborative approach to patient care. And lastly, we just heard from her, but probably doesn't need an introduction, but we will. Dr. Shana McCormack is an attending physician in the Division of Endocrinology and Diabetes and an assistant professor of pediatrics at the Providence School of Medicine at the University of Pennsylvania. She is also a member of the Raymond A. Wood Foundation Scientific Advisory Board. All right, so we are going to start taking some questions. I'm going to let a few more people in here. And let's see, we have a few already queued up. Hang on one second. Okay, so on the subject of the name change for diabetes insipidus, which is definitely interesting news. First of all, just maybe some general impressions of the name change from the panel. Good move and how long do you think it's going to kind of take from that name, from the initial proposal till that name's more widely accepted?
Yeah, I can start since I shared that paper. I think the Miriam, Chris Crane, and the other colleagues who've worked on this have done a terrific job of getting a lot of support from a lot of different groups. So the fact that they're taking their consensus statement to different professional societies and have gotten a lot of support, I think is helpful. I think if the ICD, the next iteration of the diagnostic coding system takes it, that will accelerate things, and then we'll all have to go through kind of a period of transition. I'm curious what Dr. Blevins thinks on the adult side. I don't know how you because it seems as if that's where a lot of these problems had arose from Miriam's paper.
Yeah, sure. I've long time been a proponent of the name change. I have mixed feelings about it because on the one hand, it's nice to be able to compartmentalize what you have into one of two boxes, either diabetes insipidus or diabetes mellitus. And then as a patient or family member, you can educate the healthcare professional as to which type of diabetes it is. And I'm concerned that when we start talking about arginine vasopressin resistance or deficiency, more people aren't going to, or less people are going to know about vasopressin than they are about diabetes. So on the one hand, it's good because it becomes more specific and we're naming a disorder after the underlying problem rather than the ancient Greek names that talked about an insipid urine, passage of large amounts of urine. So I like it for probably most situations, but I'm a bit of a traditionalist as well. And I still like some diseases are named after those original descriptions, but I think it is time for a change just to improve the health and quality of medical care for people who do have this disorder. So yeah, I'm all for it, but I do have some reservations about it.
I think I overall like the name change too. I think it will separate those conditions more easily. I will tell you, I've even seen, unfortunately, even in my clinical practice here, in our endocrine clinic, where we're checking in both patients who have diabetes mellitus and insipidus, where our staff gets confused and starts doing point of care testing for my patients. So I even see that, unfortunately, in a situation where we should be expert in being able to understand which condition is which. So I do think that maybe a more descriptive name will allow that to happen less often and people to really understand the conditions. I think, from a time standpoint, I usually with these kinds of things in medicine, it takes a very long time from deciding that we should change a name to it actually sticking and becoming the standard. This has happened with other, conditions over time as well, where we're trying to change things to make it more descriptive or specific for the condition. So time will tell how long it will take to do that.
So for practical purposes, would you recommend if someone was to get an medical ID bracelet right now made, should they include this name on it, or should they stick with DI or try it? I think just, from that perspective.
I think for now, I would probably maybe stick with what we all use currently. I think that makes the most sense to be the most safe, so that someone quickly looking at an ID band, if there's an emergency, will know what the name is and kind of spelling the whole name out, diabetes insipidus. I think that would probably be the safest way to go at the moment.
Okay.
Part of the problem is that we need to have, it needs to occur in a graduated fashion, and it has to be done properly to enable someone, if they saw AVP deficiency on an armband, that they would know how to go to the internet and look that up. I think you're going to find out the right answers if you go look up diabetes insipidus versus looking up AVP deficiency, arginine vasopressin deficiency. I haven't done the search comparison, but I think that when you think about the purpose of an ID band or communication of this is what afflicts me, it needs to be something where people can readily, if they don't know the answer, that's forgivable because they maybe have never seen it. But if they've seen it and don't know it, that's unforgivable. But we certainly want them to be able to go to a widely used resource, such as the internet or the library or wherever, and find the information they need to care for patients. So there's going to be a huge amount of push to try to get this word out there, I'm sure.
By the way, if you look up ABPD, you get something else. You got avoidance personality disorder. So like anything else, you have to sort of test the waters on.
Mm-hmm. Great. And just a reminder to attendees, you're welcome to raise your hand and ask the panelists questions directly by using the raise hand feature in the reactions tab on Zoom, or you can post your questions in the chat and we'll read them. And Patricia Gilroy says, in the Facebook group, Got Diabetes Insipidus, we are recommending that everyone use diabetes insipidus in parentheses. So both are used, and at least in the least, it should be AVP deficiency. So it's her comment there. And on the topic of diabetes insipidus, AVP-D, can this be cured over time is a question. Can DI resolve over time in hypothalamic pituitary brain tumor survivors?
So I have some patients that the ones that are not on a very high dose of desmopressin, some of them are able to get off the treatment, at least for some prolonged period of time. So I have seen that, whether they're, I wouldn't say they're cured. It's not like we're injecting vasopressin secreting cell, but some of them have never been fully depleted to begin with.
Yeah, I'll add our colleagues at Mass General are putting together a series, and it speaks to how, I would say, relatively infrequent it is for DI to go away outside that immediate post-op period, right? So in the operative, right after the operation, there are folks who have transient diabetes insipidus, but then kind of going months out, it is unusual for folks to stop requiring it, but it does happen. So stay tuned. Maybe in a year or two, the paper will be something we look at.
In the adult population of patients who have pituitary surgery for whatever reason, we have plenty of adults have craniopharyngiomas and other interesting lesions that are often seen in childhood. you do see improvement in a significant number of people, significant meaning far greater than you would expect. So maybe 10 to 15%. And if you look at people who've had pituitary surgery, usually if they still have the condition 6 months out, it used to be told that they would never have recovery, but there are reports in the literature of people recovering from DI 8 years later. And it's believed that the neurons in the hypothalamic nuclei, the supraoptic and paraventricular nuclei that produce vasopressin, grow new terminal boutons that dump into the median eminence instead of down into the posterior pituitary. And as long as your osmoreceptors are working fine and can communicate with those cells, you can release vasopressin in response to changes in osmolarity. And that can improve over time as they grow those new terminal endings into the median eminence part of the hypothalamus that abut capillaries. So it probably explains it. I see it in people with inflammatory pituitary conditions. I've had 2 or 3 people this year stop vasopressin after about 4 or 5 years. So it can happen, but what you notice is that those people have a less reserve, if you will, so that if something happens, if they're on a drug or they get a cold or whatever, whether there's vasopressinases or they're pregnant, it can unmask the diabetes insipidus. And it sort of speaks to the fact that most of us have plenty of vasopressin producing neurons, and we can take a hit and lose a certain number of those, get below a critical threshold, have mild DI, lower, have more severe forms of DI, ultimately with full DI if we have no neurons whatsoever. But if you have enough of those going back, you can be pushed back over that threshold where you can discontinue your medications, or maybe take it every 2 to 3 days. I have a few people that have gone from daily to about every 2 to 3 days now. So there is some hope.
And I've seen a few patients as well who've had, maybe partial resections of the pituitary gland for various reasons, who did have even prolonged periods of diabetes insipidus that maybe were mild. And I have a few kids who stopped having diabetes insipidus even a year after treatment. So I do think that these cases are out there. There has additionally been studies that have looked, I think, at, actually doing stem cell, kind of attempting to do stem cell replacement to recover some pituitary function. Unfortunately, I don't think that those have been successful attempts, at least in mouse models, but one never knows what the future will hold, of course.
Yeah. And this is an interesting question because I've stopped on forums before seeing this, but just kind of on forms, when you're filling out forms in doctor's offices, et cetera, do you answer no to diabetes if you have diabetes insipidus, or should you specify? What would be your advice there?
That's a great question. I think usually if it's sort of a non-endocrine kind of clinic, they're probably talking more about diabetes mellitus. Mm-hmm. So I think probably in those settings, I probably would not check that box, but I would probably check other, which usually is some sort of write-in to be able to put other conditions and maybe specify that as a diagnosis in that spot.
Agreed.
That's another reason to build the momentum for the name change.
Mm-hmm.
But I don't think too many of those forms are going to put vasopressin deficiency on them, but I think it's still going to go to a section of anything else, whatever, those review assistant forms that some clinics I've seen them, they use it, you could have 1,000 things on that list, but diabetes, or we're usually referring to diabetes mellitus because it's a relatively common condition. But no, I wouldn't recommend that a patient check positive for that unless they also want to write insipidus on the side. If you could enter that in.
Yeah, thank you. Nicole, you have your hand raised. Would you like to ask your question?
Sure. I'll turn my video on. So I just had a thought as the doctors were talking here. I don't know how to put this exactly. So after the surgery, I think maybe about 12 weeks after surgery, they did like the stimulant testing with the cortisol and all of that, and decided we needed to be on she needed to be on hydrocortisone and kind of all of like the traditional medications that go along with the craniopharyngioma, right? And now we're, maybe 3 years out, and she's doing really well. My daughter is. She's had radiation, and we're noticing that she doesn't seem to really need the DDAVP as often. the hydrocortisone dosage is really, really low. Is there any sort of, would there be any reason to go back in and see, like, do some of that testing again and just see if maybe she doesn't necessarily need to be on all of this stuff? Or is that just like wishful thinking and I'm in, pie in the sky?
I'll start with this one. I have gotten this question before, and when people have questions about it, especially if there's a reason, like the requirement for medication has gone down, like there can be a number of reasons why medication needs go down, but there are ways to get started looking at it. And your observations are really important. And so I'm always open to revisiting. And, we always like to have folks on the lowest amount of medicine they need. So, even if the function is not like complete, if folks can do well with the lower dose, like that seems reasonable. I'm curious what other practices. Yeah.
I always think it's reasonable to question things if, certainly if it doesn't make sense that the conditions are still there. I think a little bit, it depends on the story, so, how the condition came about and how many hormones are missing and things like that might give you some evidence to say, this is probably not something that's likely to go away. But, I've written actually on, even thinking about transition care from pediatric to the adult world. And I think in that transition, it's important actually to think about that again, so I do think there's times in life to think about, are the diagnoses still present? Does it make sense that you're still needing this treatment? Because it's not always the case that they remain present depending on sort of how that went about.
I guess that was kind of my questions. Like, are there like certain points at time where we kind of revisit, you know what I mean? Like we made a lot of decisions, you know what I'm saying? And then that's the end of it. And now we're looking back, 3-4 years out going, some of the conditions that elicited all of these responses aren't necessarily present. And so, yeah, so I think it's probably more likely a conversation to have with like her personal doctor, but I didn't know if it was like, once you're diagnosed, you have it, and this is your life, you know what I mean? But yeah.
Yeah, and that makes sense. Yeah, I think it's a journey, right? And so that journey will help decide to some degree, how much you need to keep your thyroid replacement intact. And, some of these things will help with making that decision process as you go forward. And I think probably for most of us, in this field, I think we're open to thinking about that. But yeah, to some degree, again, if you have a lot of these diagnoses that are present and they have not seemed to go away, we know that, in that case, the majority of the time, these conditions will not disappear.
I think it's an important question because we do indeed see improvement. And sometimes it's shocking that a patient can come off hormone replacement when you didn't expect that would ever happen. And many times it occurs years later. And I think a good physician is going to be paying attention to the little caveats of care and recognize, oh, this is curious. The lab results have changed. I may not need this drug any longer. And that's sort of the doctor's job. The patient and the family's job is to also inform the healthcare providers what they've observed, as you've noticed. Anytime diabetes insipidus improves, there's a chance that anterior pituitary function is going to improve as well. So it's always worth taking another look. You can see the improvement in the eye without that because you've got different things going on that regulate anterior pituitary function, which is largely a vascular connection with the hypothalamus, versus the posterior function, which is a neural connection with the axon. So improvement in one isn't always followed by improvement in another, but it certainly should raise the eyebrow that things might be better and things need to be readdressed.
Thank you. Let's switch gears a little bit and move into growth hormone. Someone asked, I've heard about trials for weekly GH injections instead of daily. What are the early findings? And I'm not sure, Shana, if you touched on that, so my apologies.
No, thanks for that really good question. I imagine you've seen the studies of weekly growth hormone. So there are weekly growth hormone formulations. I'm curious what my colleagues' practice is. The studies that were done to obtain FDA approval for like once a week instead of every day growth hormone did not, as I understand, include folks who were survivors of cancer or had brain tumor related deficiencies. They were more for like either idiopathic, meaning we don't know why, but we think maybe the pituitary is not working the way it should. So because the brain tumor survivor, cancer survivor population can be unique in some ways, we are, at least as the community at CHOP, and I'm curious what my colleagues do, a little more cautious about perceiving just yet, before there's some more experience that accumulates about how those behave. I see Vince nodding. Is that how you all are thinking about things at Texas too?
Yes, yeah, I would agree completely with that conversation. So I think that the data is really, that was been done is really driven on how do people grow on treatment. And I think they've shown very nicely that people grow just as well with weekly growth hormone versus daily. The challenge, of course, when we're thinking about long-term complications from that treatment is that in a short study, you really can't answer that question. And so they did not include brain tumors, people with brain tumors, because there's still this theoretical concern or risk of, does growth hormone somehow change things? And in the study, from my reading, we see these levels of growth hormone after an injection for some people go really high, higher than what would traditionally happen in people with daily treatment. And so I have not recommended doing that yet for anyone with a prior brain tumor because of that concern. I just don't know that I can tell anybody, for certain that it's safe. That to me is the question. And I think, yeah, more time probably will need to go by before we feel comfortable with that as a community. But yeah, interested if anyone else has any other opinion about that.
Dr. Blevins, should adults be worried about growth hormone deficiency?
It's a very good question. There's been plenty of research in that area. I've been addressing that concern with patients for over 30 years now, and I think absolutely. Untreated adult growth hormone deficiency is not a situation I would want anyone to have to experience firsthand, with all of the complications and consequences of growth hormone deficiency, and especially growth hormone deficiency over time. The longer you have it, the more severe it is, the more consequences you're going to have of the disorder. And I've treated probably well over 1,000 patients with growth hormone, and I would tell you that probably 95% of patients note dramatic, marked improvement and see improvement in some of those parameters that we're following that sort of can give us an idea as to whether or not the treatment's actually benefiting them more than in a psychological way.
So which parameters are you focusing most on? Because we always say in pediatrics, there's bone, there's general well-being, there's lipids and cardiovascular and things like that.
Yeah, we look at it all. For my patients, the thing that usually prompts me to want to test and evaluate is sort of the clinical history of a pituitary disorder of some type, and the complaint of fatigue and poor exercise capacity. Mm-hmm. Most people have decreased exercise capacity, and that translates to housework, yard work, going to work, etc. Exercise. Brain fog is very common. Changes in body composition are important, with an increase in fat mass and a decrease in lean mass, and increase in abdominal girth. I did some research when I was on at Vanderbilt. We looked at all the different cardiovascular markers that are affected by growth hormone deficiency and improved with treatment. And those are certainly such that we believe the data about the higher cardiovascular risk in patients with hypopituitarism that may largely in part be due to growth hormone deficiency. There was a study from Sweden that looked at isolated growth hormone deficiency in adults. They had a genetic mutation leading to that growth hormone deficiency and compared them to their families. This is one of these areas where people didn't leave the valley. They stayed there for their lives, and they had all the birth and death records, and found that people with growth hormone deficiency lived about an average age of 48 years. Their unaffected siblings lived to 72 years. People in the community in general lived to 70 years. And it was really the first experiment of nature, if you will, that suggested that there's decreased survival with growth hormone deficiency. And then you add on the lipids and the bone disease and the osteoporosis and the complications of that condition. If you start fracturing hips and things like that, it's important. A 30-year-old might not think it's important, but when they're 70 or 60, it's probably going to have been important for them to be treated with growth hormone. So I think it's very important. And even in patients with craniopharyngioma, My practice in craniopharyngoma patients is as long as their disease is stable and treated, and stable means no growth after radiotherapy or surgery or whatever for a year, I'll consider replacement of growth hormone in that patient. But we watch them like a hawk with MRI to determine if they need any additional treatment. Same thing is true of chordoma patients and meningioma patients. They have to be a year out from their last therapy with no growth before we'll treat. And I see dramatic improvement in quality of life. And most of my patients would not want to stop treatment. So when you see those type of responses and have that supreme compliance, it's the patient telling you that this is important to me to continue treatment.
Yeah, I mean, Dr. Blevins, that was a lovely summary. And I would only add to that the Julia Crowley's research that she presented earlier studying fatty liver really came from some clinical observations of some patients who whose fatty liver improved in part related to growth hormone replacement, right? So, so one of the many metabolic complications that you're speaking to, and I think doing it thoughtfully, of course, and like monitoring closely in collaboration with the patient. But I think that the group is probably getting the vibe about.
It's interesting. Years ago, I had a chance. I don't know if any of you know Barbara Lippy, but she was a pediatric endocrinologist, and she was in industry for the longest time. And she gave this wonderful presentation about growth hormone deficiency in the transition period. And she talked about the focus of the pediatric endocrinologist was always on growth and height. And she showed photographs of these children that she treated that were increasing in stature over time with treatment. And she said, look at what we missed all along. We missed the metabolic issues. Most of these kids were overweight. And then they lost all this weight. She showed these before and after pictures and said that now she felt like the shift should be on the fact that growth hormone is a metabolic hormone, not necessarily just there for growth. And I think she's right. It does play a role in intermediary metabolism of fats and certainly the effects on the glucose. We all know that because of the dawn effect and things of that nature. But she's right. And some of those cardiometabolic things or body compositional changes do increase the risk for heart disease as you get older. So I think it's important to consider at all ages, and certainly when it comes to transitioning people who are on growth hormone as children. Obviously, many of them had idiopathic growth hormone deficiency and don't have deficiency as an adult. But certainly with craniopharyngoma, I think the data are about 97% of people test deficient as adults. So I tend to try to work with my pediatric colleagues and share with them that information and just recommend that everybody not be told you finished your height, you can come off treatment, because they tend not to build good bone density and they start to gain weight right after. So I'm a big advocate for getting those people transitioned and retested for insurance purposes and then back on treatment if they're the 97% who still have deficiency.
A question that commonly comes in, and we'll ask this too on the growth hormone topic, is people have reported that when their children's growth plates close and they start, they no longer need the human growth hormone. And I've heard that a lot of times. What does the caregiver do or a parent do in that case? Should, to advocate to continue it, or is that a legitimate issue? Please shed light on that topic.
Well, I'll start with that one because really Dr. Blevins just said it all, that there's a role for growth hormone in those that are profoundly growth hormone deficient, not some of the people that wouldn't be invited to this conference because they just have very mild growth hormone deficiency as part of a growth hormone workup. And I bring that up because if people know it's summer camp and that there's 3 people on growth hormone, those are probably not the kids we're talking about. They're the kids that are at this conference. So I think it's important for the provider, it's on us to bring up that this isn't a treatment until the bones fuse, but in terms of growth prognosis, it's all related to the bones fusing, because once you get a bone age, which shows that the bones, you could see that there's no possibility for more than a few millimeters of growth. But the provider should bring it up. But now that you've been to this conference, if your provider has not brought it up, I think that if your child is more than age 10, that it might be good to bring up, say, just curious, and what you're feeling that after growth is completed on the role of growth hormone. If they say, well, you don't really need it, then I think that you should realize there's a lot of other people that feel strongly the opposite.
And I think Dr. Alter already talked about how parents can be a really good advocate. And I think you're the best advocate often for your child in terms of what is out there in the literature, or what's out there in the community, and maybe what should be considered and recommended. And I think particularly for patients who have again a history of a brain tumor as an example, and have many hormone deficiencies, I think the chance that you're going to have growth hormone deficiency in the long term that will need treatment is again very, very high, probably greater than 95%. So I think that's the thing to kind of remember. And again, that transition time may be a time to reevaluate things, and that's okay to do that if that's what the provider's sort of recommending, and maybe slightly adjusting the dosing for adult dosing. But continuing treatment is very important.
Yeah, that was a great point. I would also mention the two, and Amy I know is sharing the talks, but the two consensus guidelines that I referenced in this that were published this year, one specifically focused on growth hormone and the other in treatment of, more generally treatment of hypothalamic pituitary dysfunction in cancer survivors, both have sections that summarize the role for growth hormone in adults. So nice to be able to point to those consensus guidelines. And I think Vince is pointing out something that if folks aren't familiar, I think is a good point to be made, that the dose does change between childhood and adulthood. So that certainly is appropriate to revisit. Like now that the growth plates are closed, does the dose need to be adjusted? That you can expect, but not necessarily reflexively coming off.
And kind of a final, again, I know this comes up again, the latest research shows that growth hormone does not cause tumor regrowth. So when a patient has a recurrent craniopharyngioma, the question is, should growth hormone be continued or stopped? But I think that we have learned that continuing is okay at this point.
Well, so this is a nuanced question,
okay,
potentially, because the questioner who asks, like, is it that you stop because you're about to have radiation, chemo, you're about to have cranial something done, in which case this is where collaboration with the oncologist is really important, but many oncologists will recommend pausing the growth hormone during the active treatment. I think that Craig can correct me, but our colleagues in Neuroendocrine would usually do that. But then that a recurrence wouldn't necessarily mean that you wouldn't potentially go back on, but they might recommend, depending on what treatment's being pursued for recurrence, to pause during that. Much the way it's Dr. Blevins mentioned, like, our consensus guidance is to hold off a suitable interval afterwards, and what that suitable interval is changes over time and changes by the person, but that kind of clock might restart.
Okay.
When you think about it, the data do show, the only data I'm aware of where you might see growth or recurrence of a tumor is that in children who had craniaxis radiation for leukemia, there's a slight hint that they might, or trend that they might have a quicker recurrence. I think that came from St. Jude's in the 1990s. But there's probably no real harm in keeping growth hormone levels normal, if you will. If you treat the IGF-1 to your IGF-1 target for age, and the therapy is normal, there shouldn't be harm. We're certainly not whacking out the pituitaries in kids that have partial deficiency and have enough growth hormone to make them growth hormone deficient because they have a craniopharyngioma, if they're lucky enough to have normal function. And we see a number of people at UCSF where the surgeon's done conservative work and they have normal pituitary function after surgery for cranio. So we're not making them growth hormone deficient to decrease their risk of recurrence, or if they have a recurrence, we're not going in and taking out that pituitary gland. So what's the harm in continuing a normal dose of growth hormone in a patient when you're not making the other kids who are normal deficient? So that's a philosophy that I've adopted with some of my patients when I give them the choice as to whether they want to continue treatment. Obviously, the FDA says that if you have an active malignancy, you have to stop treatment. So certainly we'll do it for there. But even my patients who develop breast carcinoma on treatment, they have a family history. They don't want to stop their growth hormone. They want to have normal levels because they feel so better. But it's sort of one of the big conundrums as to what to really truly do. In adult patients, I indicated that I wait a year for no growth before starting growth hormone. But if they have a recurrence after I've already started it, I have that discussion with the patient as to whether they want to continue. Because I think it is a stylistic thing and an interpretation and medical decision making that's based on taking everything into consideration and not just treating a patient as a member of a population and following some guidelines.
Thank you. And let's maybe move on to energy and hypothalamic obesity to wrap up this session, because there's some questions there. So Jeff asks, any advice on medications for energy? I'm so sick of feeling tired all the time, 23 years, and I still have found nothing other than dextroamphetamine will actually help. And she's still tired, exhausted on that medication. Any advice there?
That's a challenging question, I would say. So I think we know that, unfortunately, I would say after many types of brain tumors that there are often changes in the amount of sleep and energy that people require. So I see that as a really, really common complaint, and not one that I always have a complete answer for. I do think that stimulants do have a role there in improving energy, expenditure, to balance weight, and also actually just improving energy. Often our team in the sleep medicine department here use stimulants really, really commonly actually to manage that energy or increased sleep that people may develop. And so I do think that's a really good drug. I definitely understand the feeling of being stuck on a medicine or feeling like, there's not a way out of that. And I don't know that there's a direct way to kind of completely come off of that those medications if they're helping you. But I do think that those medications are really, really, really important and helpful for people that I see.
Yeah, I would add first the empathy that like, oh man, fatigue is tough and low energy is tough. And this is where having a good collaborative relationship with either your primary doctor or your endocrinologist or whoever is, managing can help, because people mean different things when they mean low energy. Like, do I fall asleep easily? Can I not keep up, during exercise? Like kind of drilling down as to what impacts you adversely mostly. Vince mentioned like our colleagues in sleep medicine, like, is there sleep disordered breathing? Is there circadian problem that might be amenable to those treatments? Like, how is thyroid being replaced? How's hydrocortisone being replaced? Is growth hormone being replaced? Are there medicines being taken for other reasons that are contributing to fatigue? Is there a role for focused physical therapy because maybe deconditioning or cardiac problem is contributing? So, I mean, unfortunately, it should be illegal, but it's not for folks to have any number of other health problems as well that could be, kind of adding to fatigue. So having someone be able to take like that kind of that big picture view. We've had, patients with anemia or nutrition, micronutrient deficiencies that contribute to their energy. So I wish I could say that, yes, you will go get a comprehensive evaluation and folks will find all the, causes and fix it. And then your energy will be what it used to be. I think, that would be misleading, but there are often ways to at least chip away at the problem and, to work together with folks who are interested. Dr. Blevins, I imagine for your adult patients, fatigue and low energy is a complaint you encounter commonly too.
It is indeed very common. And my usual approach is to first optimize all hormone replacement therapies. And what I mean by that is that we don't simply aim for normal level results. So if a patient, for example, has fatigue and their T4 levels and their T3 levels are in the middle of the normal range, I might bump the dose up a notch to get them to the 3/4 part of the normal range, for example. And the same with growth hormone. If their IGF-1 is normal, but in the the middle, I might want it to be at the 75th percentile, so to speak. So I'll make these fine-tune adjustments, maybe change their steroid supplementation around a bit, talk to them about their sleep. And one of the big causes of fatigue in adults anyway is depression. And if I think they have a depressed mood, I'll recommend they talk to their primary physician or a therapist about such, because sometimes antidepressants are all they need. It's difficult having a chronic illness and taking multiple medications and scheduling doctor visits on a regular and routine basis. So sometimes people do need some psychiatric help as well.
Okay, so let's see. I just want to remind the attendees, thank you. I just want to remind the attendees that we do have a limited amount of time. I'm trying to keep the questions in topics. I did miss one on growth hormone, so if you don't mind pivoting back just briefly, someone asked if there's any issue with growth hormone replacement being used with inhibitors in tumor treatment. And again, that might go with the fact that really during active treatment, maybe it's paused for that time.
I think sometimes the practice, so I'm glad for the opportunity to clarify, like really I work so closely with our oncologists and they're not on this call. So that's why I think all of us, like anyone who's in active treatment, I think one of the questions I see, like from someone who's got a low grade tumor, it sounds like who's getting treatment indefinitely or for a long time. So they say, well, does this mean never? And so in my own practice, not necessarily, it means talking individually with the family and with oncology, like, hey, is this reasonable to do? Do you all feel like we can do this? And can we start can we use very low doses and monitor very carefully? Because like anything, it's a risk benefit balance. And there are some unknowns with respect to the theoretical risk of treating someone with growth hormone deficiency who's receiving active treatment or radiation, as someone else has asked, but I don't think there's any clarity from the data that there's clearly one way to go. I think our own approach at CHOP that I think has worked is for us to have very thoughtful conversations with oncology about like, what's known, what's not known, and what's true about this patient in front of us with respect to the symptoms they're experiencing from growth hormone deficiency, and what kind of unknowns can we tolerate with respect to either course that we take. Being aware of the issues and having a thoughtful conversation, I think, is the most important thing.
Thank you.
And I agree with that too. I think that I always tell people that there's sort of three people that need to be in the room whenever we're talking about using growth hormone. That has to be the family, first of all, endocrinologist who's prescribing the medication, and then the oncologist who's actually treating the patient for their condition. And I usually tell people that all three of us need to be in agreement generally that we should move forward. And I definitely don't think that there's a single paintbrush for every patient, to saying, completely no to use of growth hormone either. And I think as long as we're kind of understanding what the data says and what the potential, benefit and risk is and weighing those things, I think it can definitely be done even on a treatment.
Thank you. Switching gears. Is there any side effects of not addressing testosterone deficiency for a very long time? The same person asked, is there any chance of comeback from testicular atrophy? Because one of the side effects of the tumor was infertility. We did several cycles of fertility meds and sperm retrieval, unfortunately to no avail.
Yeah, that's a good question too. I think in terms of a couple of questions there, I guess. So in terms of testosterone replacement, or basically giving hormone replacement for testosterone in one way or another, I do think that it's important, and there can be health implications if that's not done sort of in the right time frame or manner. One of the big things, kind of from a long-term standpoint, is the accrual of bone, which does happen generally during your teenage years. We know that people who are really delayed with the timing of puberty induction can have long-term implications on having low bone health and possibly a risk for osteoporosis at an earlier age. So that's one of the implications. And then there's a lot of social implications in terms of that timing being really delayed compared to peers and social interactions and maturity, right? Because the brain obviously also matures in relationship to getting exposed to puberty hormones. So all those things are really important. The second question then is really about fertility, I guess, in boys specific, kind of specifically in that conversation. Yeah, and I think fertility for boys is a tricky one, because I think often the time frame that we start to really pay attention and think about that, sometimes is a little bit late, to be honest with you. There are some studies that show that even having very early signs of changes with testicular function may already be too late, where people may have what we call azoospermia, or lack of sperm, maybe sort of like what you experienced. And I think it behooves all of us to kind of be really on top of that in the community, in the endocrine or fertility community, to try and get kids who are boys particularly early to, sperm bank, if that's a goal for the family, and have that conversation very, very early, hopefully before treatment, to understand what the risks are and when to maybe proceed with doing sperm banking. So that's sort of my thought process, is trying to really communicate that up front and have a plan about what we can do and when to do it.
As an adult physician, we often see that children are treated, or boys, I should say, treated with testosterone to help them go through the pubertal changes and, facilitate bone growth and muscle growth and voice changes, et cetera, to go through puberty. One of the things that we see on our end of it from fertility is if a child goes to a normal puberty with the pituitary stimulating testicular function, they're more likely to have a response to HCG and FSH when they're adults. And it makes me wonder why we don't treat boys who have pubertal failure due to a hypothalamic or pituitary lesion with FSH to sort of get those testicles geared at that early age, because I think what you said is right on target. The earlier you have that intervention to sort of bring the Sertoli cells to functional level, the more likely you're going to respond as an adult when you really want your fertility. So I would encourage some studies in that arena to try, just HCG and FSH stimulation during childhood. It'd be interesting to see if sperm counts were better and fertility as an adult is going to be improved.
And Dr. Blevins, you're right on target there. So I actually do that. And I think some of us in the community are trialing that ourselves as endocrinologists. I think traditionally that's been done in the fertility kind of arena as adults. But there are some studies that have looked at protocols on how to give HCG and FSH, which are the signals to the testicle to grow, actually for puberty induction. So I know that I've been doing that for a little bit of time now, and particularly for kids who are, craniopharyngioma survivors, as an example, who maybe don't get drugs that affect the testicle. Those are the ideal targets where everything is really ripe to be started right away.
Absolutely. So many people are living a full life. Except they get 30 years of age, they meet someone they want to marry, and they can't have kids.
Yeah.
So I think it's what you do when they're 14 or 15. It's going to really matter.
I think
I'd
so
love
too.
to see that to become a standard of care. It's the direct stimulation there. It's expensive, and insurance companies might not want to pay for it, but maybe that's where a foundation can help for those boys.
Well, I think that I will speak in not really contrary, but just give the other side of that. And just for the people in the audience, the testicles, for those who have a boy who have, let's say, craniopharyngioma, the testicles work fine. They're just not being told to make its testosterone. So the proposal and the idea is, why not give them something that would make the testicles work, like replace the normal pituitary hormones. And now we don't do it for thyroid. We don't give TSH. We just give thyroid hormone because it's so easy. And for testosterone, it's a lot easier to give, let's say, once a month testosterone to start initiating puberty. HCG is, you may say, why HCG? Isn't that the pregnancy hormone? Because HCG is very structurally similar to that LH and FSH that will tell the testicles to get to work. And that ideally we would want to give the pituitary hormones, but it's expensive, they're not approved, and they're HCG. I don't know what protocol Dr. Horne's doing, but it's typically like 3 times a week. I am shot, but maybe doing sub-Q more frequently, but it's a lot more expensive and hard to get approved. Dr. Dr. Peter Snyder, who's at Penn in 1985, did a really good study and looked at those who have hypopituitarism from any cause. Could be cranial, could be at birth, not from a tumor, just genetic reasons, and found that those who were so early that they had undescended testicles did not do well when the fertility stimulation attempt as an adult was tried. But those who had fully descended testicles and maybe had a craniopharyngioma, they did pretty well.
Yeah, and I actually agree with you about the controversial comments about using it as well. I think one idea to do this would be to use it for just the time for induction, and then actually sperm bank and switch over as one way to get at the cost concern. And there are more injections that are required for using this treatment compared to testosterone for sure. And I would also point out that it's a little bit controversial, in terms of the effect of just giving testosterone on fertility. I think some people feel very strongly in the fertility community that testosterone can be toxic to the cells that make sperm, while others in that community feel very strongly the other way, that even if you get that they're able to still produce sperm and still have children on their own. So it is a little bit of controversy there, and it's definitely not, I would say, the standard of care or the traditional method that we've done. But I do think thinking about ways to, think about fertility in the long term, again, is a big deal. If you ask most adult survivors, just as what was mentioned by Dr. Blevins, one of the #1 factors that affect quality of life is, in fact, fertility. So I do think thinking about that in the long term for these children and ways to maybe improve that for the future is important. I think more studies are needed for sure.
Thank you. On that topic, I'd like to wrap up with a few HO questions, and then we are out of time. So switching again, back to hypothalamic obesity, a question about wearable glucose monitoring devices. Since we've seen them out a lot, they're more widely available, is there any known or suspected relationships between glucose level spikes and hypothalamic obesity? And maybe if so, is a monitor something that would be useful in that application?
That's a really interesting question. And I know that, so for example, Mary Ellen Bajervelu at Michigan is looking at, not specifically in hypothalamic obesity, but in kind of other forms of obesity, folks who might be at risk for type 2 diabetes, like what do those continuous glucose monitor readings mean? Because our clinical experience with them, of course, starts in folks with diabetes mellitus, not diabetes insipidus, right? That's where they start. A couple of thoughts. One is that some folks and colleagues out at UCSF, maybe of Dr. Blevins, Rob Lustig, had looked a lot about higher insulin levels in folks with hypothalamic obesity. That can sometimes translate into blood sugar fluctuations, but not always, or not always directly. The other consideration is that I know some of our patients have had success with nutritional approaches that either limit the amount of carbohydrates and or the kind of carbohydrates that might be expected to produce blood sugar fluctuations. I'm not aware of larger studies looking at continuous glucose monitoring as an outcome in hypothalamic obesity, but it's a really interesting question for folks who find it helpful, who, for example, learn about how different foods affect them. That's an approach that's been used kind of in common, quote unquote, common forms of obesity, and to kind of tailor nutrition recommendations. It's certainly an intriguing one that could be studied more. So I appreciate that suggestion. What would others add?
Yeah, I actually agree with you, Shana, about the comment about sort of high insulin. My mentor, Susan Rose, also helped with the publication of some of those articles. And so my knowledge of this is not necessarily that, patients have a lot of diabetes mellitus actually, or sugar diabetes. I feel like I see that maybe even a little bit less often than I would expect. But we have seen, I've actually participated, in actually, following things like insulin excursions. And I do think that patients who have hypothalamic obesity, one of the mechanisms why they may be gaining weight is that they secrete a huge amount of insulin. And we know that insulin can actually drive, sugar into cells and actually, adipose tissue and cause weight gain. And so, Dr. Rose and others have published some articles looking at ways to actually use medications that lower insulin as a way to lower weight and have shown to be somewhat effective. So I don't know as much about using glucose monitoring devices other than to say, what you mentioned too, which is that perhaps understanding those excursions may help you better understand foods that may cause excess glucose that may then drive, weight gain after you eat them, and possibly that might be a way to kind of monitor what you're eating to lower weight.
Thank you. And Vicky asked, any guidance on DVT or stroke prophylaxis for a child with chemo radiation treatment and now with pan-hypo-pit and HO?
Yeah, that's a great question. And I think the question may be in response to the paper that I presented from our colleagues in Connecticut who were reporting on several cases. I think my impression is that what would be most important would be to identify those with the current care team, right? The risk in the particular child and when they might need specific intervention. So for example, like during hospitalization and during illnesses and in all of our hospitalized patients in the ICU, for example, our ICU colleagues, like as one of the things that they consider and everyone consider clot risk and ways to reduce it. I think the fact that the question is getting asked or is on all of our radars now when we think about these patients, to think about the risk of blood clots is really the most important step, because the role for prevention really needs to be individualized, other than all of the other kind of great things that one can do, minimizing obesity, staying active, managing DI well. Those are kind of common sense things that, of course, we would want for the patient anyway, right? So as to whether or not they would need specific like mechanical devices that we use in the hospital or medicines for some people, that would be a question for the care team, but a good issue to make sure has been considered.
It may be worthwhile to also point out that, after radiation treatment, some kids may be at risk for damage to blood vessels that go through the basal ganglia, which is one part of the brain. That condition is called moya-moya disease. And we know that kids who get radiation are already more at risk for having some changes there, after that treatment. And it's not always easy for us to know who will get that or how to prevent that, I would say. But this has come up as a question about managing fluid balance, as a way to potentially help with blood flow through the vessels. And I do think that keeping on top of, managing that well and making sure those medications are working consistently for people probably is an important aspect of that, that I think families could utilize for themselves.
Yeah, it's an important consideration. I was just sitting here thinking, I have had 3 adult patients with hypothalamic obesity die suddenly, and 2 of those we knew died of a pulmonary embolus. One of those had severe diabetes insipidus, or vasopressin deficiency, we should start to say now, and had gone to the pharmacy to get the medicine refilled. And this was a Medicare or Medicaid patient. And the pharmacy said, "You've already had 5 prescriptions this month. You can't get your medication." And so she basically got behind because she had adipsic hypernatremia and died about 5 days later. Her father took her to a hospital emergency room and they checked her blood. Her sodium was 192. And he left the hospital before getting the result back because it was taking too long to get her from the ER into the hospital bed. And she died the next morning, probably of severe dehydration, but it was found to have pulmonary embolus. And so it's a real problem. And I think that avoiding dehydration is a key prevention. Whether or not patients should be on blood thinners or not has never been studied, probably won't ever be studied, but it is real. It's a question that came up, and my advice is avoid dehydration with diabetes insipidus if you also have obesity. And a lot of, if you think we talked about earlier, you showed the video about the things that happen with increased energy expenditure, food intake, increased metabolic rate, et cetera. People who are overweight the brain's actually telling them to try to move more, because if it's working normally, but people who have hypothalamic obesity, they also have a decreased activity level, and it's important to keep people moving, even though they may not want to get off the sofa or out of bed. You've got to keep people moving if you can. That's the biggest prevention you can do to decrease the blood clot opportunity. That and don't get dehydrated.
Thank you. We are unfortunately out of time. So I wanted to thank our panelists so much for your insights and taking the time with us to answer our questions. It's so appreciated. And thank you to our attendees for joining us today and for these great questions. And someone did ask if we're going to do this in person, and that is our goal. So hopefully next year will be an in-person event. We'll still offer a hybrid for people that couldn't attend in person. So thank you all so much. Again, thank you to our sponsors, Consonance Therapeutics and Rhythm Pharmaceuticals, for making this possible, particularly our translation options. And we invite caregivers and survivors to join our networking sessions, which will open up at a quarter after the hour. So again, thank you all so much.